All right, so hello and welcome to today's webinar on the CERT Part A errors and the 2 midnight rule. My name is Rachel Wood, and I'm going to be the speaker for today's webinar. I'm joined by my fellow nurses in provider outreach. Mary Sue is going to be helping with our chat today. We also do have some of our CERT review nurses on as well for any questions that might come in. As I said, we will be answering questions through the chat feature. You can send those to all panelists. If we don't get to your question, or if we run out of time, or maybe don't have an answer for you today, we will respond via email. So just keep that in mind as we go through our slides this morning. All right, so here we have our disclaimer. Basically, our disclaimer just tells us that Medicare does change their rules from time to time. We are presenting on the rules and regulations as they stand today, January 31st of 2024. But if anything does come out once we conclude our webinar from Medicare that changes anything we've talked about, that does take precedence over our presentation this morning. Additionally, no recording this yourself. I am recording this, and we are going to be posting this pending the outcome of the recording on our YouTube channel, so you can take a look at it at a later date, just to check back and maybe show a coworker that couldn't make it. Just some acronyms here. Please refer back to this. CERT, the Comprehensive Error Rate Testing. That's what that stands for, just as a review. And then the rest of these on here are pretty straightforward. So please refer back to that if you have any questions. So now on to our agenda and our goal for our webinar today. So I'm going to start by talking about the CERT program and just provide a little bit of background on, what that is, what the review process looks like, and what you might expect if you are in a CERT claim review. And then we're going to talk about the Medicare 2 midnight rule, providing just a review, I should say, of what that includes, and answering some of our pre-submitted questions and talking about some of the documentation that we're looking for, or I should say CERT is looking for the 2 midnight rule. Additionally, we're going to answer pre-submitted questions, and then if we have time, we will answer questions anything that came through the chat at the end of our webinar today. All right, so I want to first talk about what CERT is. So I'm going to cover why the program was developed and talk a little bit about how it works. So let's start with the why. So why was CERT developed? And hopefully this helps you all listening understand the importance of the CERT program. So CERT was put into place to replace the Office of Inspector General, or OIG, estimated improper payment rate. The OIG sampled a small number of claims, and that was about 6,000. So due to that relatively small sample size, the OIG was unable to produce an improper payment rate per contractor. So the Payment Integrity Information Act of 2019 allowed Medicare to create the CERT program. The goal was to provide a national improper payment rate, and this is shared with public as well as with Congress. This provides a larger sample size. So Medicare also shares their results on the CERT improper payment rates with claims processing entities for the claims that they go through. And for the purposes of just defining what that is, that would be the MAC, so the Medicare Administrative Contractor, which is us at WPS. Medicare does contract with a separate company who is not a MAC to perform the medical review part of the process. So I do just want to make that clear that we are not reviewing these claims. We do help with, gathering information, and I'll go through a little bit about that when we get to that next slide. But again, we are not the contractor that is reviewing the information for CERT reviews. That is a separate contractor or separate company. So this contractor, they have a medical professional review a stratified random sample of claims, and the review results are used to determine that CERT error rate. Any claim that is processed by Part A and B MACs, as well as durable medical equipment MACs, are eligible to be selected for a CERT review. All right, so how do we use this information and how does WPS come into play? So at WPS, we provide education on the common errors, so some of the information we're talking about today. We pull data on the common errors to determine if there's a bigger problem, if there's a problem we're seeing, at the local level and a lot in our jurisdiction, or we adjust the system edits and audits to help prevent future errors. So that's not an all-inclusive list, but it is just some actions that, MACs and WPS can take and how they correlate with the CERT review results. All right, so that brings us to the types of improper payments. And on this slide, I've listed the major category errors that CERT looks at and reviews for. If an error is found, they do assign it to a category. So these include no documentation. That one is pretty self-explanatory. The other categories are insufficient or missing documentation, coding errors, so incorrect coding, medical necessity issues, as well as other. So the final one would be that the claim doesn't fall into any of these, but it also doesn't meet the Medicare guidelines. So I'm going to talk about each of these briefly individually. First, insufficient documentation. This is the #1 error that is assigned. This means a provider sends documentation in, but it does not support or does not provide enough information to support the service that is billed. This category is assigned for a couple of reasons. One, documentation, again, does not support the Medicare payment for the service that was billed, or it is billed at an improper level, or it's not medically necessary, so the information sent in doesn't meet the Medicare coverage guidelines, or finally, a specific documentation element was not included. So maybe we're missing an order or we're missing a key piece of information that would, provide the full picture of the service to be covered. The next category is incorrect coding. So this is assigned when a service is medically necessary. Medicare will allow the service, but the code submitted does not support what is in the documentation. So certain services might be coded at the wrong level. This category can include coding the incorrect place of service as well as discharge status. So these errors result in overpayments, underpayments, or no payment errors. And then we have medical necessity. So this error category is assigned when the billed service does not meet the medical necessity under Medicare coverage and payment guidelines. So sometimes this can be based in policies and program provisions. And then that brings us to our last category, which is, again, as I said, others. And this would just be when the other categories do not apply, but it is still something that we, find improper payments for. So that's kind of that catch-all final category that CERT can put stuff in. So with these errors, the provider is notified as well as WPS, and then we would take action to adjust the claim. So this could be either an overpayment, which would mean a letter would be generated asking for money back, or the adjustment can create an additional payment, which means additional payment is due to the provider, and then that is sent as necessary. All right. So here is a list of the steps of the CERT process, and I'm going to just briefly go through this. It begins with the claim selection. So the next step would be that the CERT review contractor requests records. Once they receive that information, they review those records and find the errors as they apply. So if the review contractor determines an improper payment, they then assign them to one of those improper payment categories that we just went through. So this again can include Part A claims and Part B, durable medical equipment as well. So the CERT contractor selects claims on a semi-monthly basis or twice a month. And both claims that are paid and denied by Medicare or MACs, so WPS, can be included in that final CERT sample. So just something to keep in mind. So once claims are selected, the medical record requests are going to be sent to providers by that CERT review contractor. They're going to be sent to that corresponding address in the provider enrollment file. The review contractor will review the information sent back to them, and again, look for that improper payment, determine if yes, it exists, no, it does not. If there's no error, no additional contact is made. If there is an error, again, we notify, or they notify the provider and then notify WPS. So after looking at the record and the information that CERT has reviewed, WPS will also take a look at this. If we agree with the error, then we will take the corrective action to recover that overpayment or, again, make that payment to the provider as necessary. That's kind of where our nurse reviewers come into play. Often the WPS will contact providers to try to access additional documentation to reverse that error. We do have a dedicated staff that is responsible for these tasks at WPS. As I said, some of our CERT nurses are on our call today, and if you find yourself in this situation, they might be, somebody that makes a call out to you, and you might find them, corresponding back and forth to try to get that error resolved. All right, so that is just kind of an overview of what CERT is, what some of the background is on it, and what the process is if you find yourself in a CERT review. So I want to move now into the 2-midnight rule and talk about what this is, and we're going to start with just a brief overview, and then we'll talk about some of the documentation elements that the CERT review contractor looks for and we commonly see missing in our CERT reviews for these requests. So to start, what is the 2-midnight rule? So way back in 2012, Medicare identified high error rates of errors for hospitals that provided services in medically unnecessary settings. So what we mean by that is inpatient versus outpatient. Medicare also observed a higher frequency of beneficiaries treated as hospital outpatients receiving extended, quote, observation services. And there was concern expressed about, what this trend, what this trend represented, especially since hospital outpatient days do not count towards 3-day inpatient hospital stays. That is a requirement for Medicare coverage of skilled nursing facilities. So in response to these issues and these concerns, Medicare provided some additional clarity to hospitals and other stakeholders on those inpatient admissions to be paid under Medicare Part A. And that brings into play the 2-midnight rule for admissions, hospital admissions, beginning on or after October 1st of 2013. So this rule established Medicare payment policy regarding the benchmark criteria that should be used when determining whether inpatient admission is reasonable and payable under Medicare Part A. All right, so in general, the 2-midnight rule states that inpatient admissions are generally going to be payable under Part A if that admitting practitioner expects the patient to require a hospital stay crossing 2 midnight and the medical record supports that reasonable expectation. The 2-midnight rule is generally not appropriate for hospital stays expected to stay to not span those 2 midnights. So we're looking again for the expectation of 2 or more midnights. This rule does specify that all treatment decisions for the beneficiary need to be based on the medical judgment of physicians or other qualified practitioners. It does not prevent the physician from providing any service at the hospital, regardless of the expectation during of the duration of the service. So for those stays that physicians expect the patient to need less than 2 midnights of hospital care, and that procedure is not on that inpatient-only list, which I'll talk a little bit more about in a few slides. An inpatient admission would be payable under Medicare Part A on a case-by-case basis, again, needing judgment documented by that admitting physician. So it's an expectation, though, that those situations would be rare and not the norm, but, you know, so ideally, we're looking for that expectation of staying 2 or more midnights. So that is what the 2-midnight rule is. I just kind of want to briefly define inpatient versus observation. So because of the way Medicare structures their program, there are different payment rates for inpatient and outpatient hospital stays. So Medicare will pay for acute hospital stays, so those in the inpatient status under the hospital inpatient prospective payment system. That is for Medicare Part A. So in contrast, Medicare will pay for observation status, so those that have not yet been admitted to the hospital with the hospital outpatient prospective payment system. That is paid under the Medicare Part B program. So not all care provided in the hospital setting is appropriate for inpatient Part A payment. That is just why I wanted to kind of define the difference. So again, when a beneficiary comes, a Medicare beneficiary arrives at the hospital needing medical or surgical care, it is up to the physician or qualified professional to provide documentation and determine whether it's appropriate to admit that beneficiary as an inpatient or treat them as an outpatient. So, and depending on that determination, that's going to depend on how the payment structure then follows. Briefly wanted to touch on also evaluating levels of care. This is something that is done, on the hospital level during the review process, evaluating the level of care required for the patient in question. So it's done on the real time, so, evaluating when the person's actually pursuing the care, as well as done aftermath to look at, what is information included in their hospital records, and does that meet the information on what level of care they should or should not have been receiving. So I'm not going to spend a lot of time on this, but considerations for level of care provided include the patient's medical condition, the specific needs, and the risk associated. There are a lot of tools out there that are used by hospitals to evaluate levels of care. So, InterQual is something that's commonly used. I know that the CDC also has a tool out there. There are a variety of other ones as well. Regarding the 2-midnight rule, the use of these tools do not replace the documentation for the patient's need to be admitted and the support of documentation to admit the person for 2 or more midnights. So these evaluation tools can be used for support and to guide that decision, but do not replace other documentation of the provider's determination that Medicare patient requires to be admitted for 2 or more midnights, and why. All right, so onto the inpatient-only list, and the 2-midnight rule, just want to be clear on this, the 2-midnight rule does not apply to services on the inpatient-only list. So that is why I wanted to talk about this briefly. I'm not going to spend long, it's a very long list, so we're not going to pull it up, but I did just want to include this slide because it can be a little tricky to find. If you're not familiar, in my opinion, it's not very obvious to find out where this actual list is housed. So you To find it, you can go to the CMS website at cms.gov, choose Medicare, and then under the hospital outpatient payment, under the fee physician, Medicare fee for service payment category, and then choose hospital outpatient regulations and notices. It's going to be on that left side navigation. And then I know that's kind of fast instructions, but from there, you can select the final rule for the current year. And then you're going to want to go to find Addendum E and open that up. And that is where the inpatient only list is housed. So I know that that's a bunch of steps I went through and I did not show it, but we do have a link to a YouTube video that we did put together. I believe Mary Sue put this together, and it does a really great job of providing instructions on how to get to that file and how to open it. So we did include a hyperlink to that in our slide here if you would like to go out and review that later, just to check and see if the service in question is on that inpatient only list. All right, so documentation for the 2 midnight rule. So what are we looking for? What is CERT looking for in the documentation for inpatient admissions that support the 2 midnight rule? So I'm going to go through this in a little bit more detail in the next few slides. So first and foremost, documentation should support that admitting physician has the expectation the patient requires hospital care spanning at least 2 midnights. So this can be for a variety of reasons. For that reason, we don't have, there's not a end-all, be-all of document X, Y, and Z, because it is going to vary, depending on the patient's problems, their presentation, their history, and the other things going on as to why the provider does decide to admit them and expect them to stay in the hospital for 2 or more midnights. So this does include stays in which the physician expects the person to stay 2 or more midnights. It's supported in the documentation, but the actual length of stay is less than 2 midnights due to a variety of circumstances. So examples could be the patient dies before they're expected to pass away. Maybe they're transferred to a different facility or unit. They have sudden clinical improvement, or maybe they have sudden clinical decline on the other end and have to go someplace else to maybe a more specialized facility, or, we know patients also leave commonly, unfortunately, against medical advice. And so departure AMA is something that would also kind of fall under that, leaving before those 2 midnights. One thing we want to stress, and our medical directors that work with CERT wanted us to stress, is that an order alone for inpatient admission does not support the inpatient stay. So we are going to be looking for documentation that has that order, so that signed physician inpatient admission order. We also are looking for the provider's documented expectation for the number of midnights, clinical rationale that supports the medical necessity of the inpatient admission, and then evidence that hospital care cannot or should not be delivered as outpatient when the risk of an adverse outcome is significant. So again, this is, we can't provide, document X, Y, and Z specifically, but these are the things that we're looking for, clear pictures of the things that I just went through based on the provider's clinical judgment. All right, some documentation considerations to include in the medical record. So the medical record must describe the patient's clinical status that supports that inpatient admission. So this can be documentation of comorbidities, and that would apply to medical or surgical stays. So per Medicare guidelines, this is appropriate for inpatient procedures and does not apply, as I said, does not apply to those inpatient only services that are on that inpatient only list. It does apply to newly initiated medical ventilation, as well as any of those rare and unusual expectations where inpatient admission is payable on, Part A case-by-case basis. As I said, for those case-by-case basis situations, we do expect the admitting physician expects the patient to need less than 2 midnights of hospital care, but they still believe an inpatient admission is still reasonable and necessary. This must be very clearly supported in the medical record. All claims are subject to medical review, so just because you've done a bunch and didn't put an order or didn't put an explanation for that 2 midnight or those needing the 2 midnights and nothing's happened, those claims can be reviewed later on. So you do want to make sure that the documentation, again, supports this information that we're going through, just in case, later down the road, your facility does get selected for a CERT review. So common documentation errors that CERT typically sees. First is missing support for medical necessity of the inpatient stay. So, we need to see, and I feel like I've kind of gone through this in those prior 2 slides, but reasons for the patient need to be admitted inpatient for that specific stay, so not past days or what they were admitted previously, what they specifically need in that stay during that inpatient admission, what makes admitting them inpatient necessary versus their ability to stay as an outpatient. Why does the provider think this is medically necessary, and what interventions or services will that person be receiving while they're inpatient? What symptoms are you going to be monitoring as during their inpatient admission, and why can those symptoms and those services not be monitored in a different level of care? The next error we commonly see is documentation that contains the physician order for inpatient admission only. So kind of alluded to this already, but an order is something that we are going to be looking for. It is required, but an order alone does not support the rest of the kind of piece of the puzzle. So an order should be included, but it should also be included along with the documentation that provides that additional information supporting the need for inpatient admission and giving a little bit more insight on that practitioner's decision to admit inpatient. And then finally, the final error that CERT sees during their reviews is that providers will send in no order for inpatient admission and no clear reasons why the person was admitted versus they stayed, could be treated outpatient or observation. So that one, kind of just sums up the reasons why we would need that. I've went through, but we do see that, unfortunately, more often than we think, that there's no order for inpatient status and no other information. Just the person was admitted, and we, on the review end, don't 100% know why, and it's unclear. So make sure that that is something that is included. All right, so before I get into our pre-submitted questions, I did just want to briefly touch on Medicare versus Medicare Advantage plans, because we did get some questions in the pre-submitted question section that asked about updates to the 2 midnight rule for this year. Those updates would apply to Medicare Advantage plans. WPS provides content and education and does interacts with claims for original Medicare, so Part A and Part B. Medicare Advantage falls under that Part C. So there are a lot of articles, and it can get a little confusing if you just Google 2 midnight. A lot of times the information that comes up is going to be relating to Medicare Advantage plans. Again, we do not provide education on these plans, but if you do want guidance and specific guidelines relating to midnight. For Medicare Advantage, you do need to check out those plans' websites and their contents that they put out regarding education and their specific policies and so on. So I just wanted to kind of touch on that just to make it clear, because I know sometimes that can be a little confusing, and there's a lot of contractors that are involved within the Medicare program. So we just deal, again, with original Medicare. All right, so just to kind of sum up what I've gone through today before I go to our question section, I talked about a lot. We went through the CERT program and a little bit about who they are, how they develop, and that process. And then I talked about the 2 midnight rule, so what this is, who it applies to, and some of the differences of inpatient versus outpatient, and then some of the documentation considerations to include to support that inpatient admission decision for providers and the common errors that are seen during the CERT reviews. All right, so wanted to talk here about our pre-submitted questions and go through some of these that were sent in through the WebEx platform during registration. So first question, are Medicare Advantage, or are managed care organizations going to be held to the 2 midnight rule as well? So the 2 midnight rule, as I just kind of mentioned, first of all, this is not new to Medicare, as we've gone through. This has been in place for original Medicare for quite some time at this point. Information that we've gone through today applies to original Medicare, so Part A and Part B, but we're talking about Part A facilities for inpatient. Managed care organizations are going to follow Medicare Advantage or Part C guidelines. So again, not something WPS or other MACs handle. The 2 midnight rule does apply to these Medicare Advantage plans, but for specific information on how that applies and more details, providers should look at the specific Medicare Advantage plan for more rules and regulation information. Next question we got: any chance the 2 midnight rule will go away? So unfortunately, this is out of our control, and it's not something that we do have any kind of impact on. To our knowledge, the answer to this, though, is no. We do not have any insight or any information that the 2 midnight rule is going anywhere anytime soon. We do encourage providers, if they have thoughts and want changes to be done to the Medicare program, to send comments to CMS, maybe through the professional groups, because sometimes that can be a little bit easier to put together a strong case than just one single person. So any changes that you want, we do suggest you sending that in. Medicare does look at the greater provider community's comments for feedback on changes. But again, at this time, we have no knowledge of the 2 midnight rule going anywhere. All right, so next question, will claims be denied solely on the fact that there is no documentation of expected number of midnights for the inpatient stay? So I want to reiterate that the documentation should support that the admitting physician expects the patient to require hospitalization that spans at least those 2 midnights. We recommend using clear language, so something along the lines of, expect patients to stay at least 2 midnights to monitor and for X, Y, and Z, progress changes, et cetera. The CERT review contractor's expectation of the following should be documented in either the physician assessment or the plan of care, or, again, somewhere in those notes that are sent in for supporting that determination for inpatient stay. So expected level of stay and the determination of the underlying need for medical or surgical care at the hospital, again, should be supported by complex medical factors, including history, comorbidities, the severity and signs of their current symptoms, current medical needs, and any risk of adverse events or reactions, and so on. Specifically, a separate, attestation statement of the 2 midnights. This is not something that Medicare in their guidelines specifically requires, but it is information that does need to be evident and clear throughout that physician's standard documentation. So again, that plan of care through the treatment orders or in that physician's notes. The easiest way to do that, again, is by using that clear language of, expectation X, Y, and Z to stay for, X number of midnight. So kind of long-winded for that answer, but moving on to our final question that we got, can you clarify when the 2 midnight benchmark starts for a claim selected for medical review? Is the outpatient time prior to the admission included in determining the general appropriateness for the inpatient admission? So this answer is, we got it from the, just information from CERT, as well as some of the CMS frequently asked questions response documents. For the purpose of determining the 2 midnight benchmark, whether that was met, CERT will consider time that the beneficiary spent receiving outpatient services in the hospital as well. But this will include services, so observation services, treatment in the emergency department, and so on. But for medical review perspective, the time that the beneficiary spent as a hospital outpatient before they were formally admitted as an inpatient, this is not considered inpatient time. So this time will be considered when they're looking at the process to determine, whether the 2 midnight benchmark was met, and therefore whether payment for the admission would be appropriate under Medicare Part A. For example, when the beneficiary receives services in the emergency department, which as an outpatient prior to being an inpatient, or is formally admitted as an inpatient upon arrival to the hospital, the starting point for the 2 midnight time frame for medical review purposes will be when the beneficiary starts receiving services following the arrival to the hospital. So this excludes time that the person has spent waiting in the waiting room, or they're receiving triage activities such as vital signs while they're waiting, again, in that hospital waiting room. So to kind of give another example, somebody sitting in the emergency department waiting room at midnight while they're waiting to start treatment would not be considered to have passed that first midnight, but a beneficiary receiving services in the ED at midnight, they've already started receiving the services, they would meet that first midnight benchmark. So the review contractor, again, is only going to count medical necessity services that are related to that person's clinical presentation that are provided by the skilled medical staff in the hospital. So hopefully that answers that question. Moving into resources, we included the 2 midnight fact sheet, frequently asked question document from Medicare, and then a link to the Code of Federal Regulations that talks a little bit about the 2 midnight rule. So take a look at those if you have more questions. And I want to pause here. I don't see any questions, but so I'm looking through the chat, and I don't see any questions. So if you do have any, please send those to us through our WPS email. And otherwise, I'm going to just wrap it up and thank you all for joining us today. Hope you have a wonderful rest of your day, and hope to see you in future WPS live events. And you may now disconnect.